Hello and welcome to the session. I hope you're taking good care of yourself. Today's topic is about COVID-19 in children, the most important and most prevalent topic because we are going through this pandemic now. So today I'm going to discuss and highlight all the latest management guidelines which have been published as per IAP and Ministry of Health and Family Welfare, that is MOHFW guidelines, which have been published in April 2021. So without any further delay, let us dive into the latest guidelines. First of all, what is the case definition? As per WHO surveillance guidelines, it can be a suspect case, probable case, or a confirmed case. Now, coming to the epidemiology, we know that the spread of infection is basically direct person-to-person transmission, which occurs because of close contact and mainly through the aerosolization of the respiratory droplets that are released when an infected person coughs, sneezes, or talks. These droplets can also land on surfaces where the virus remains viable. One thing that we have to remember is that in case of children, they might not be affected by the severe type of infections or the severe forms which we see more commonly in the adults, but they are mostly the asymptomatic and pre-symptomatic groups or categories of infection, but they are still able to transmit the infection and spread the infection. As a result of which, it is very important to know about COVID-19 in children as well. And the median incubation period has been found according to studies as 5.1 days. It can range from 2 to 14 days. As per current evidence, the period of infectivity starts 2 days prior to the onset of symptoms and can last up to 8 days. So coronavirus mainly spreads through touch, sneezing, and coughing. That is why even when children are playing at home, if an infected person has sneezed and held a surface, suppose a table or something, and at the same time the child also holds the table, touches the table, and then immediately touches the nose or the mouth, the child is also at risk of getting the infection. That is why our actions are also extremely important and our precautions are also extremely important when we are dealing with children. Now, why is COVID-19 less severe in children? There are actually multiple causes for this, so I will just briefly tell about them. First of all, the differences in the endothelium and clotting function. With aging, there is wear and tear of the endothelium, and what happens is the SARS-CoV-2 virus or the COVID virus basically attacks the endothelial cells and causes vasculitis-like syndrome. So in case of children, the endothelium is not that damaged as in case it happens with aging. With aging, there is a damaged, worn and torn endothelium. So because of this less pre-damaged endothelium and a difference in the clotting and coagulation function, the COVID-19 affection or infection is less in case of children. Next, coming to the important point of angiotensin converting enzyme 2 receptors and transmembrane serine protease 2 receptors. Now, ACE2 receptors are the most important cells, and they are the target cells which are used for the entry by SARS-CoV-2 cells. So these SARS-CoV-2 virus, it is going to gain entry into the body through these ACE2 receptor cells. And these cells are prevalent more in the nasal and the lung epithelium, liver, kidney, CNS, and other organs as well. But the number or the density of these ACE2 receptors increases with age. Also, in children, the ACE2 receptors have got very minimal affinity towards the SARS-CoV-2 virus. So because of lesser number, as well as very low affinity, it becomes very difficult for the SARS-CoV-2 to invade these ACE2 receptor cells in children. Also, 6 to 8% of the acute respiratory infections in case of children is by the other non-virulent or the non-serious human coronaviruses. As a result, there is some amount of minimal pre-existing immunity from those infections as well, which exists in case of children. Then coming to immunosenescence, inflammaging, and chronic CMV infection. Now, basically, as with aging, there is a phenomenon of immunosenescence or aging of the immunity system as well as the cells. As a result of which, with aging, the innate immunity starts fading, which can be seen or which can be exemplified by the factors that there is less antigen and pathogen uh, identification by the body, also the decreasing of the innate immunity, and so on. And inflammaging means pro-inflammatory type of state. And this pro-inflammatory state is also along with aging. So with age, the body stays in a pro-inflammatory sort of a state, as a result of which COVID-19 infection symptoms and the signs are much more exaggerated in adults as compared to children. Comorbidities has got a very strong association with COVID-19 infection, and we have seen that well. Then lower levels of vitamin D. Now, vitamin D has got antioxidant properties and anti-inflammatory properties. It helps in preventing many respiratory infections. Also, it tries to kill viruses normally during the respiratory infections. So, if there are lower levels of vitamin D, you are more prone to having the COVID-19 infection. So now coming to signs and symptoms of COVID-19, there are typical and atypical symptoms. In the typical symptoms, we have fever and headache, running nose, sore throat, chest pain, cough, pneumonia. And atypical symptoms mainly comprise of GIT symptoms like vomiting, pain abdomen, diarrhea, and skin rashes. And another entire spectrum of symptoms is the multisystem inflammatory syndrome of children, or the pediatric inflammatory multisystem syndrome, MIS-C or PIMS. So now coming to the clinical phenotypes of COVID-19 in children. There are basically 4 phenotypes. There is a pre-symptomatic phase, which is the time period between the exposure to virus and the development of symptoms. And even during this period, mind it that the child may be infectious. As we had seen that 2 days prior to the onset of symptoms and 8 days following the onset of symptoms, the child is going to be infectious. Then asymptomatic phase is where the child's test is positive, but there might be no clinical symptoms and signs at all, and the chest imaging is also normal. The child is infectious. Classical manifestation, as we see, is by fever, cough, cold, shortness of breath. But there are many children, even in my OPD, I have seen that many children have firstly come only with GIT symptoms. And later, when we have got history that in parents or in relatives, somebody was affected by COVID-19, and I have tested, it has come positive. So atypical symptoms are mainly the GIT symptoms. Certain children have got non-purulent rashes, and then we have the spectrum of MIS-C. Now coming to the diagnosis. In diagnosis, PCR test or RT-PCR test is the mainstay of diagnosis. It is still the most confirmatory and the mainstay form of diagnosis in India. Apart from that, in the guidelines, now CB-NAT, that is nucleic acid amplification test, expert and TrueNAT have also been included. And the benefit of TrueNAT is that the test results can be obtained in around 3 to 5 hours of time, whereas in case of RT-PCR, we need at least 24 to 36 hours. CRISPR-mediated detection is a newer form and still not optimally validated. Other forms are antigen detection. Now, rapid antigen test, which is very commonly used, the basic thing is that it has got a high specificity but low sensitivity. So, if a RAT test is positive, then we are going to take it as a COVID positive child. But if it is negative, we still cannot rule out the infection, and we will have to confirm by RT-PCR. So these are point source, point based tests. And then we have antibody detection for IgM and IgG, but that may not be helpful in case of acute infection detection. For these, the respiratory specimen, the best is nasopharyngeal and oropharyngeal swabs. Apart from that, we can have BAL and even sputum tests. Now, coming to the testing criteria, these all things have been these are all the guidelines that are given by IAP and MOHFW. So testing is recommended for all the suspect cases in order to avoid transmission to other family members prior to any procedure or hospitalization. But if the resources are scarce, then testing may be deferred for both asymptomatic contacts and children with mild symptoms and no comorbidities and a known positive family member. Such children have to be presumed COVID-19 infected and therefore managed as per the IAP guidelines. Now coming to the management. So according to IAP, the classification has been done as per disease severity, as per clinical symptomatology and disease severity. The disease can be classified into mild, moderate, and severe. First, coming to mild disease. So mild disease is only the symptoms of fever, sore throat, rhinorrhea, cough, diarrhea, vomiting, and no fast breathing. Okay, so this is only the non-specific viral prodrome kind of symptoms which comprises of the mild disease. So for treatment of mild cases, this can be OPD based and home based treatment itself. We have to do thorough counseling to the caregivers and the or the parents to warn them about what are the things they have to be continuously monitoring for. We have to ensure proper hydration and breastfeeding in case of children. No role of antibiotics at this stage. For fever, it's only supportive management. So for fever, paracetamol 10 to 15 mg per kg can be repeated every 4 to 6 hours. For cough, we will only advise warm saline gargles. And although multivitamins are told, but it does not have any proven value, but it can be given. And we have to continuously ask the parents to look for red flag signs like rapid breathing, SpO2 of less than 95%, persistent high fever, poor feeding, or lethargy. So the take-home message for mild case treatment is that at this particular phase, for mild cases, there is no role of the big shot names like hydroxychloroquine, favipiravir, ivermectin, lopinavir, ubifenavir, or remdesivir as well. Immunomodulators including tocilizumab, interferon B1A, convalescent plasma infusion, or dexamethasone. There is no role of any of these for mild cases. But it's only dependent on the monitoring chart, because a mild case can convert into a moderate or a severe case if not monitored properly. So we have to ask the parents to count the respiratory rate 2 to 3 times per day, look for signs of tachypnea and respiratory distress in the form of chest indrawing, cyanosis, bluish discoloration of body, grunting, cold extremities, decreased urine output, monitor the saturation continuously and note it down, and to look for fluid intake and whether the child is active or not. Now coming to moderate case. So moderate case is when along with the viral prodrome, you also have fast breathing. So age-based fast breathing, it is stated as tachypnea when the respiratory rate is more than 60 in case of less than 2 months of age, more than 50 for 2 months to 1 year, more than 40 for 1 month to 5 for 1 year to 5 years, and more than 30 for more than 5 years of age. Or if there has been presence of hypoxia, which is given by an SpO2 of less than 95% on room air, and there can be no signs of severe disease. So moderate disease is the viral prodrome or mild disease symptoms plus the addition of tachypnea or presence of hypoxia. So for treatment of moderate cases, now we have to admit in dedicated COVID-19 hospital and COVID-19 ward and look for investigations in order to rule out other infectious causes. So CBC, complete blood count, CRP, chest X-ray, RFT, and LFT. If the SpO2 is more than 94%, we have to maintain proper hydration and good oral feeds and give paracetamol and plus minus antimicrobials if we are convinced that there might be a bacterial superinfection. And antimicrobials that have been allowed are IV amoxicillin or coamoxiclav or ceftriaxone. If the SpO2 is less than 94%, then we have to start oxygen and with that IV steroids, plus or minus antimicrobials, and the use of remdesivir has to be completely decided by the pediatrician in hospital setting and under emergency authorization only. Next, coming to severe disease. Now, severe disease is when there is pneumonia with any of these, that is saturation of less than 90%, increased respiratory effort, grunting, severe retractions, or lethargy, seizures and somnolence, severe diarrhea, vomiting, and abdominal pain. Critical disease, which is a subset of severe disease itself, is defined if any of these is present: ARDS, shock, multi-organ dysfunction syndrome, and acute thrombosis. So for treatment of severe or critical cases, we have to admit the child to a COVID-19 ICU or PICU, and then do the investigations, that is CBC, CRP, RFT, LFT. We have to add inflammatory markers like procalcitonin, D-dimer, arterial blood gases, lactate, ECG, and chest X-ray. If needed, then tropoid, 2D echo, ferritin, LDH, and these can be repeated at 24 to 48 hours, judging on the clinical condition. We have to start oxygen, and non-invasive or invasive ventilation needs to be decided. We can start with CPAP for the younger children, and for older children, HFNC and non-invasive ventilation can be considered. Consider prone positioning and restrictive fluids if we are already suspecting ARDS. And in these cases, definitely IV steroids with oxygen administration has to be given. With that, depending on the other investigations, we may or may not need enoxaparin, antimicrobials, and remdesivir. Now we have to manage the shock, that is give bolus or IV fluids. And if it is not getting corrected with IV fluids as well, then an early inotrope needs to be added, because time is of essence in these cases. However, if there is ARDS and we have gone for invasive ventilation, in that case, low tidal volume, high PEEP type of ARDS ventilation and restriction of IV fluids is required. AKI, HLH, and myocarditis have to be managed as per the protocol. So as per IAP management statement, so for these are the various dosages of remdesivir, steroids, and antimicrobials. Remdesivir up to 3.5 to 40 kg, more than 40 kg. These are the ways we have to be given, but remember that it has to be used within 10 days of onset of symptoms and the child is on oxygen. And it is contraindicated if ALT, AST is more than 5 times normal or if the creatinine clearance is less than 30 ml per minute. Steroids, we will be starting with dexamethasone, so 0.15 mg per kg of IV dexa once daily for 5 to 14 days, and then we can change over. Antimicrobials, as I told already, it is IV amoxicillin or co-amoxiclav or ceftriaxone. And with that, enoxaparin, less than 2 months, 1.5 mg per kg per dose every 12 hours. For more than 2 months, it is 1 mg per kg per dose every 12 hours. So respiratory support can be given in the form of HFNC. So heated humidified HFNC can be used if the target SpO2 can't be achieved. And this may be preferred over BiPAP or CPAP in case of older children. We start at 0.5 liter per kg per minute and increase up to 2 liter per kg per minute. Use minimal flow so that the child is comfortable. Target an SpO2 of 90 to 94% and always monitor the vitals and look for work of breathing. If still there is increasing or worsening work of breathing and there is no improvement, we have to plan for escalation of the respiratory support. And even when we are giving HFNC, we have to provide 3-ply mask to the child in order to prevent aerosolization and droplet infections. So next is what is the oxygen therapy for severe COVID-19? Basically, when we have started with supplemental oxygen, we are going to target an SpO2 of more than 94% in the acute phase during resuscitation. And once the child is in stable and recovering phase, SpO2 of more than 90% has to be aimed initially. We use nasal prongs and cannula as they are better tolerated in the children. Surgical mask or hood cover to prevent aerosolization. If the child is on oxygen by nasal prongs and SpO2 is still less than 90%, we can use these ways, that is face mask at more than 5 LPM gives FiO2 of 40 to 60%, O2 hood at flow 5 liter per minute, FiO2 of 30 to 90%, Venturi mask gives 28 to 60% FiO2, and non-rebreathing mask gives at a flow of 10 to 15 lpm. That is FiO2 of 80 to 90%. So now coming to multi-system inflammatory syndrome in children, that is MIST-C. It is also known as pediatric inflammatory multi-system syndrome in case of that is PIMS. Now I will just show, as per the picture itself shows, it is mainly fever, rashes, strawberry tongue, bilateral non-purulent conjunctivitis, rashes and peeling or desquamation from the fingers and toes, and also periungual inflammation. So let us see the proper definition of MIS-C, which has been even quoted by IAP as well as Ministry of Health and Family Welfare. So definition of MIS-C: 0 to 19 years old child with fever of more than 3 days and any two of the following, that is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs of oral hands or feet, hypotension or shock, features of myocardial dysfunction like pericarditis, valvulitis, or coronary abnormalities, evidence of coagulopathy by raised PT, APTT, and D dimers, or acute GI problems like diarrhea, vomiting, or abdominal pain. With that, inflammatory markers like raised ESR, CRP, or procalcitonin, and there are no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcal or streptococcal shock syndromes, and the evidence of COVID-19 by RT-PCR antigen test or serology positive or likely contact with patients with COVID-19. So just briefly, I will also discuss the pathophysiology of MIS-C. First is the stage of early infection where there is SARS-CoV-2 infection. The child is asymptomatic or mildly symptomatic. There is nasopharyngeal colonization or mild infection, but there is no pulmonary infection due to lack of ACE2 receptors and other factors. So stage 2 or pulmonary phase is skipped at this point. These the super antigens present in this nasopharyngeal colonization that will lead to a macrophage activation, which further activates or differentiates into the helper T cells. Helper T cells will activate the B cell, which further differentiates into plasma cells that form antibodies. Now, helper T cell will also lead to release of multiple cytokines as shown here, and this leads to a cytokine release or storm that stimulates the macrophages, neutrophils, and monocytes, resulting in a hyperimmune response and therefore multi-system inflammatory syndrome, which has multimodalities like mucosal inflammation, cardiac abnormalities like ventricular dysfunction and coronary aneurysms, shock, AKI, skin changes, pulmonary edema, consolidation, and atelectasis. So as per the various studies done all over the world, SARS-CoV-2 related multi-system inflammation, the most commonly affected system in the body is the heart or the cardiovascular system. There is left ventricular dysfunction in almost 100 cases, 100% cases, shock or coronary dilatation, pericarditis are also seen equally. Then we also have digestive involvement with 83%, bulbar conjunctivitis 89%, and skin rashes are also seen in 57% of the cases. One thing we also need to know is that MIST-C is more prevalent in older children. So median age was 10 years. And one thing to remember is that there is left ventricular dysfunction or cardiovascular system is the most commonly involved. So this is the treatment algorithm as per IAP. So if we have clinical suspicion of MIS-C, that is a child is having high fever for more than 3 days, there is epidemiological evidence with SARS-CoV-2, that is RT-PCR or any serology is positive. There is clinical signs and symptoms of MIS-C as per the criteria. If these are present, we proceed for the workup of MIS-C. But first we see whether there are shock and life-threatening symptoms or not, because there are two tiers of investigations which we do. So if shock or life-threatening symptoms are not there, then we will do tier 1. But if both it's there, then we are going to do both tier 1 and tier 2, so complete MIS-C workup. And if tier 1 is positive, we further go for tier 2. And if negative, we work up for alternate diagnosis. Okay. So what are these tier 1 and tier 2? Tier 1 comprises of CBC, LFT, RFT, ABG, glucose, CRP and ESR, and or ESR, SARS-CoV-2 serology, and PCR. Other infections have to be ruled out, like malaria, dengue, blood culture, and if suspected, scrub typhus and leptospirosis. If tier 1 is positive, that is CRP, both these criteria, that is CRP also has to be more than 5 mg per deciliter, and or anyone, ESR has to be more than 40 mm. With that, there has to be either an ALC of less than 1000 or platelet of less than 1,50,000, or hyponatremia or hypoalbuminemia or neutrophilia. So if tier 1 is positive, we go for tier 2, that is cardiac, that is we do a 2D echo, ECG and TROP-T. With that, inflammatory markers like procalcitonin, PT, APTT, D-dimer, fibrinogen, LDH, triglyceride, IL-6 and ferritin. So once we are done with the investigations, now the treatment. So first I will talk about shock or life-threatening disease if present, and then if not present. So once we have confirmed with our investigations that we have a case of MIS-C, then we look for if there is shock or life-threatening disease present. If that is so, then we have to give IVIG 2 gram per kg over 24 to 48 hours and IV methylprednisolone 10 to 30 mg per kg per day. So this is high dose IV methylprednisolone. Empirical antimicrobials have to be started, and with that aspirin has to be started 3 to 5 mg per kg per day. However, it is contraindicated if platelet count is less than 80,000 or the child is bleeding. And also look for if there is any coronary aneurysm or thrombosis, or the ejection fraction is less than 35%, we have to start off with enoxaparin also 1 mg per kg BD subcutaneously. But if no shock or life-threatening disease is there, then we give IVIG 2 mg per kg over 24 to 48 hours and IV methylprednisolone lesser dose 1 to 2 mg per kg per day, and if aspirin 3 to 5 mg per kg per day. But if in spite of giving this treatment, there is no response after 48 to 72 hours, we have to repeat the IVIG, and with that consider other higher immunomodulators like tocilizumab 4 to 8 mg per kg per dose, or high dose anakinra 2 to 10 mg per kg per dose. Or infliximab as well. I have not seen cases where till now, fortunately, where I would have to give this or repeat an IVIG. I have seen a few cases where I have managed with IVIG, or and certain cases where they have not agreed for both, because we all know that both IVIG and IV methylprednisolone are extremely expensive medications. So IVIG and IV methylprednisolone have worked very well for MIS-C cases, and they are the mainstay of treatment because it's a hyperimmune response, as a result of which the whole treatment is based on IVIG and IV methylprednisolone. So this is all about the main guidelines that have been given by IAP and MOHFW for management of COVID-19 in children. And now finally coming to precautions, because we know that basically adults and caregivers are quite a lot responsible for kids being affected more this year in the second wave. Last year, pediatricians were lucky that children were affected less, but this year that is not the case. Children have been affected, and affected quite severely this year. One reason is that the virus has mutated. It will keep on mutating and come back in severe forms. But the other thing is that the sudden letdown of the guards and sudden stopping of the lockdown, people stopping to wearing masks, and then going to many social gatherings and not taking care of the precautions. So it is the onus of responsibility is completely on us. So let us just see what are the precautions. We have to continuously take up the strict precautions of hand washing, social distancing, and wearing mask. both for parent and the child, because children 2 years of age and more have to wear mask. It has been given as per IAP as well that children more than 2 years can wear mask. We have to avoid attending public functions, social gatherings, and group play as of yet, and watch for vitals and signs and symptoms suggestive of COVID in our children. If the child is serious, then no waiting and rush to the hospital. And another thing about immunization, routine immunization can be continued even 2 weeks after the child is asymptomatic. If taken high dose steroids or severe form of COVID, then immunization has to be deferred for 3 months after medication. And for all the adults, vaccination of the elders is extremely important. Now, this is even recommended in the lactating mothers. Yes, lactating mothers should get vaccinated. It is very much beneficial. So this is all about the guidelines. I hope I have been clear in explaining all of them. Thank you so much for listening. Thank you.